Awesome. All right, here we go. All right, welcome to the American Academy of Emergency Medicine Critical Care Medicine section. This is one of our recurring series of Pathways to Critical Care. My name is Dan Zumsteg, and I will be moderating tonight's session. I am the AAEM resident student representative on the critical care section, and on behalf of CCMS, we are delighted that you are able to join us for tonight's presentation. Today's webinar will be recorded and will be uploaded to our webpage within 48 hours for anyone to view. And please use the Q&A or the chat box if you have a question or a comment. We welcome and encourage participation, and we've reserved a little bit of time at the end of the presentation for more questions if there are any. If there aren't any questions, I'm going to stop my screen share, and I'm going to introduce our speakers for the evening. So first on my list, and this is alphabetical, is Dr. Wendy Chang from the University of Maryland Shock Trauma Program. She is an associate professor of emergency medicine, neurology, and the program in trauma. She splits her clinical practice between the emergency department, the neuro ICU, and neurotrauma ICU. She is currently re-exploring the Smithsonian Museum and is a big fan of the Infinity Rooms, as I understand it. So welcome to Dr. Chang. Next, I have Dr. Ali Hines out of the University of New Mexico. She is an assistant professor in emergency medicine and surgery. She practices clinically within the trauma practice and is a critical care intensivist covering the TS ICU, the neuro ICU, the MICU, and the CTV ICU. She is a pandemic Pelotoner, much like myself, although I haven't been able to commit every day to it, but looking forward to hearing from you, Dr. Hines, and welcome. Next, I have Dr. Andrew Phillips from DHR Health down in the very, very southern tip of Texas. He is the founder and editor-in-chief of emcoach.com. He is a staff physician in a rural ED and also works in their ICU as a tertiary care, which is a tertiary care center. He's the associate medical director of ICUs, the medical director of the ECMO program, which I believe he started himself, and the Women's Hospital ICU lead. He is currently potty training his youngest, which makes everything else look easy. And as I can personally attest to, he is able to give a very convincing sales pitch for his EM coach in both English and Spanish. So welcome to Dr. Phillips. Finally, last but not least, Dr. Matthew Stanfill out of the University of Wisconsin-Madison. He is a third-year resident at the University of Wisconsin and will be a fellow in the critical care transport and helicopter EMS program next year. Dr. Stanfill is closest to the application process, and when he's not applying to fellowships, he's working through the book 60 Hikes Within 60 Miles of Madison. I hope the ice trail was on there, but he's only got 10 more to go, so I assume you've already hit that one up. To get us started, Dr. Hines, I know that one of the things that you're really passionate about is caring for the critically injured patient. And I hate to put you on the spot, but could you talk a little bit about that for us?
Yeah, so the critically injured patient is a unique patient population, I think, to the intensive care units, as it's oftentimes we see kind of the spectrum of ages. And so we have kind of the younger patients, and we also have some older patients that kind of come in with ground level falls. And so to be able to see them, oftentimes they're younger and healthy. And so to be able to see them kind of go through these like outrageous disease processes in the ICU, and then seeing how they're able to kind of recover from that and taking care of them like on the floor is also like really just fulfilling to me as I sit there and kind of see their whole like length of care, which is pretty cool.
Wonderful. And Dr. Stanfill, as I alluded to in our introductions, you're a senior resident heading into critical care. Could you talk a little bit about what your experience has been during residency with critical care and how that maybe got you excited for a fellowship in critical care?
Certainly. So, in residency, you rotate in a bunch of different critical care units. You spend time in the PICU, you spend time usually in the surgical ICU, in the medical ICU. And those experiences with these extremely complicated patients and seeing them go from just this extremely deranged physiology and then reasserting control over that physiology and helping these patients to get better and then go, hopefully get out of the ICU is really cool. And then also for the patients who, even when you're not able to kind of get them back to recovery, but kind of managing the dying process and engaging with patients' families and kind of helping them understand what's going on. That's really fascinating. And we get a touch or a taste of that in EM practice on the front end, these patients coming in, but the next steps, that next layer and that continuing care was really interesting and appealing to me, which is part of what drew me into wanting to do critical care in the future.
And I understand you're done with the application trail right now. Is that correct with fellowship?
Sure. So to kind of review where I'm at. So like you said, I'm a third-year emergency medicine resident. I'm going to be doing a fellowship in med flight next year. So it's called critical care transport and helicopter EMS. And then during that med flight year, I'm going to be applying for a medical critical care fellowship.
That's exciting stuff. I admit I've never been up in a helicopter, but I'm sure it's even more exciting when there's somebody you need to take care of. Dr. Chang, I know that Dr. Hines went through the surgical critical care pathway, and Dr. Stanfield he's going from flight into medical ICU, but you're in neurocritical care. Can you tell us a little bit about what that's like?
Yeah, absolutely. I think for a lot of people, maybe you're not as familiar with neurocritical care being a potential pathway. And to be honest, I wasn't until I met people who did neurocritical care. So it's really just fortuitous in that way. After rotating through the neuro ICU in my residency, that's when I became, realized that it was available as a potential career path. Found the patient population to be also very fascinating and rewarding, a kind of a mixture of the young patients like, in their prime of their life with subarachnoid hemorrhages who could potentially have really rewarding outcomes, TBIs, et cetera, as well as, of course, our older adults from strokes and ICHs and stuff. So that's why I decided to focus on this population.
Thank you. Wonderful. Now, Dr. Phillips, everyone we've heard from so far is at an ivory tower institution, right? We have Maryland shock trauma, we have University of Wisconsin, we have University of New Mexico. You practice out in the community. Can you tell us a little bit what's different between academic and community ICUs? Because you've been in both, if I remember correctly.
I have, yeah. I did community for a while, then I did academics for a while, and I'm back in the community. And it's actually, there are different varieties of community, right? So the first, immediately out of fellowship, I spent a little less than a year at a community shop where there were no residents, and actually did two different shops. I did EM and I did critical care at two different places, and it was just me, no residents, no students of any kind to be teaching, no fellows. And I was glad I did that because it forced me to do everything myself and get my chops up, not within that broad category of residency. And then I did the academic thing and I had residents and fellows and the whole bit. And now I'm at a community place for one of the hospitals, a rural place. It's just me. And actually through plenty of the night, it is just me for the entire hospital. The closest other facility is about an hour away, and which feels like eternity when you're trying to get a stroke or an MI out, particularly trying to hit that door at balloon time. And the other community hospital is, as it sounds, a 42 bed. The whole facility has 42 beds, and the ED has 8 beds. That's the facility. As opposed to the other community place where I work has 500 beds. It is affiliated with an academic institution, but it still is very much a community hospital. And one of the big differences, it has some residents, but not every unit is staffed with residents. And so you kind of spend some time having residents and fellows, another time on your own. And there's a difference in the focus on the community. It is, in some ways it is more efficient because you're not having to, when you're rounding, the attending says to the resident, okay, so call the nephrology service to talk about maybe starting dialysis. And so the resident on the ICU team calls the resident on the nephrology service who talks to the fellow on the nephrology service. I pick up the phone on the attending on my service and I call the other attending and be like, hey, John, I think we start dialysis. And John's like, yeah, I think so too. And we're starting dialysis. On the other hand, there's not the same conversation and pollination I think is probably the best way to describe it, that when you have residents going between different services, and even within the same service, their plans are different, and their plans are different based on maybe what they've heard from other attendings. And so it's not uncommon when you're academics that a resident will come with a plan that maybe you've read about or you've heard other people do, and maybe there's ketofol, maybe like back when ketofol was first starting. It sounds reasonable. You've heard about it. They explain the plan. Yeah, sure, I'll try it. And that's part of how the processes speed up much faster, I think, in academics, because of the pollination between the residents going between the attendings and services, keeping everybody a little more up to speed, as opposed to the community. It's just kind of go, keep seeing patients and move things along. The plus side of the community is that I get to do things the way I want to, as opposed to having to take a step back and let the resident try their plan, always in a safe manner, of course, right? And I see the other academic attendings smiling that, yeah, sometimes there are gray zones. You can go either way, and you want to give them an opportunity to find their way of doing things. I just do it the way I want now in the community. Anything on the side. So some people, for example, a lot of residents and students maybe listening to this have been doing some research and gearing up towards an academic thing. And you can still do that. I'm still publishing. I'm an editor at WestJet, even though I'm in the community. Doesn't mean you can't do this stuff, but it means that I'm not scrounging for grants. I don't have my department is not set up in a way with a chair or vice chair with a certain agenda, really trying to push a certain area of research. Not to say all of it do, but all that structure is gone. It's a hobby. So I get to pick the projects that I want on the timeline that I want. And that's like 5 minutes of explanation. I'll stop.
No, that's
Have I sold the community on you yet?
I'm convinced, but so one of the things that you brought up, Dr. Phillips, was this idea of pollination, and Dr. Cheng, you're taking a sip, so I'll start with Dr. Stanfield. This idea of cross-pollination, taking your expertise in one area and coming into a different department. What do you think you're going to be looking to take or hoping to take from med flight as you go into a medical ICU? Do you have an idea yet of sort of the skill set or the differences in skill sets that can be brought into those different environments?
I've got something of an idea now, and I always have a better idea once I go through the med flight fellowship, but it does give you an appreciation, I think, for the challenges of getting some of these critical ill patients from one hospital to another. So most of the med flight transfers are from ICU to ICU. So going out to a QND hospital that's been overwhelmed by this complex patient they have that needs to then come to a more tertiary center for advanced therapies. So kind of understanding, going out to these community hospitals and seeing like what their ICUs are like, what the resources they have, and kind of transferring the patient from their system to the med flight, then to the academic system. Like, I think that's going to give me a real appreciation when I'm working in the medical ICU, being, oh, this person is calling, wants to transfer this patient. Like, kind of what are the shoes that they're in? Because I've been there on med flight and I've gone and seen that. I think that'll be one thing that'll be contributing to cross-pollination, I suppose.
Yeah, certainly. Actually, Dr. Hines, I don't know if you've had a chance to work with Dr. Whalen down at New Mexico yet, but he was having a conversation with me and said something very similar to what Dr. Stanfield was saying, where seeing the referring center makes a huge difference. Dr. Hines, you weren't always at New Mexico, though. Can you tell us a little bit about maybe the differences you've seen between New Mexico and your previous posting? Oh, hang on, I think you're on mute.
So I trained in residency more of kind of like a hybrid type institution, which is I was at Mercy St. Vincent's in Ohio, and there they have residents. The EM is very dominant of the culture because EM is usually the people who kind of respond in-house at night to anything that goes wrong, and we also make up the large overnight staff of the various intensive care units. And then I did my fellowship training at the University of Pennsylvania, which is very academic as well. And so kind of the breadth or what I've seen by different levels of training is just the amount of like resources that are available and kind of how hands-on you end up being. And so more of kind of at the University of Pennsylvania, it was not that EM can't do a lot of the things, but a lot of times you end up outsourcing a lot of the procedures that end up being the intensivists can be able to do to like our proceduralist team, while the intensive care unit team ends up focusing kind of more on just the intensive care unit things. And then at the University of New Mexico, like we end up doing everything. And so like we can do the ECMO cannulations, we end up intubating in the intensive care unit, which at Pennsylvania was done by the anesthesiologist. And then we end up also doing the trachs and the pegs as well. And so like we just have a really breadth of availability there too. And that's kind of the spectrum that I've seen with trainees. We have a large number of trainees at the University of New Mexico. We have a great emergency medicine program, which is fantastic, and they're like really protective, and they're able to kind of help us out quite a bit. And the same was also at fellowship. At fellowship, we had probably a few more residents, I would say, because all the services were resident ran versus, or for the most part, were resident ran versus now we're kind of having the split in our services where like APPs end up taking up a large proportion of the services, which is great. Like they provide excellent continuity of care. I'm just like in fellowship, it was a lot more, they worked side by side with us where we integrate them into our academic teams versus now we're kind of seeing a split of teams. I hope that answered your question.
Yeah, it did. Yeah, the variability shop to shop is something that's fascinating, and seeing the kind of things that you get into at New Mexico versus at University of Pennsylvania versus at Mercy St. Vincent. Dr. Cheng, I was wondering if I could circle around to you. You're dual boarded, if I remember my research correct. Do you find that you get to bring those skills to bear? You know, do you find that gives you a bit of an edge, or allows you to be a little bit more nuanced in your management of patients?
I think everybody in this audience definitely has that particular perspective. I think, everybody in the section also agrees that EM intensivists just bring a different perspective to both of the roles we play, whether in the ED or in the ICU, having, practice in both of those settings and helping with the transitions of care for these patients. And so I think that is a really unique perspective for people who are interested in both EM and critical care. And obviously, depending on our patient and subspecialty niches and interests, and as we dive more into that, then obviously we try to bring more of that knowledge into each of the arenas we practice.
Wonderful. And I don't know if you mentioned this before, but I want to take a step back and rewind the clocks to when we were younger and had presumably fewer gray hairs and slightly more vigor of youth. Dr. Cheng, what was it about critical care as a medical student, or when did you catch the bug? Because I got to be honest, years of training and hours in the ICU sound very exciting, but it's a huge commitment for somebody.
It's very true. I was interested when I was applying for residency already at that time, similar shoes and time frame as a lot of you guys, as you're deciding on residency programs, et cetera. So at that time, most EM people who were doing critical care were either pursuing EM/IM critical care or trauma critical care training and getting European boarded, because we didn't have all the subspecialty certifications available then. And as what you were just mentioning, Daniel, at that time, I was like, I can't commit to 6 years. It sounded very daunting. So I said, let me just focus on EM residency first. And if I still like critical care, then I'll figure out what path I'll take after that. I ended up choosing a 4-year EM residency and then fell in love with neurocritical care, which outright was already a 2-year training program. So still ended up spending 6 years in the training ultimately. But I just needed to make the decisions, in a stepwise fashion.
Fair enough. Dr. Stanfield, do you remember the moment? Oops, sorry. Do you remember the moment you got the ICU bug?
Oh, it must have been back in med school as well. So even before going to residency, I knew I was interested in critical care. And I certainly wasn't committed like 100% I'm going to do critical care, but it was something I was strongly thinking about and considering looking into those pathways. And for me, like the 6-year training thing was never a huge burden or barrier, because like I knew that any way I was going to get to critical care was going to be 6 years. From EM, people, get nervous about doing extra training because like, oh, it's so much to like, you do your residency and there's so much to do this more, but like any route you take to critical care, if you go through medicine, anesthesia, like it's going to take a number of years to get there. So, the 6 years it's going to take me to do EM, med flight, medical crit care is the same as if you did medicine and then palm crits. So.
Fair enough. Dr. Hines, was there a patient or a rotation that really like got you going for ICU?
Yeah, I was actually extremely late to the process. Like I remember having conversations at the end of my first year of residency of saying I'm not doing critical care. Like I just had a very superficial knowledge base as to what I thought critical care was. And so it was exactly that. It was a traumatic brain injury patient up in our neurointensive care unit that the trauma service was managing and following, and I took care of him overnight. And his anticoagulation had to be reversed, and just kind of like interacting with the family and having that longitudinal care, and then just kind of really getting into the details and seeing how detail oriented the process is, and like everything that kind of goes into the decisional process. Like I said, I had a very superficial level of knowledge as to what critical care was very early on in my training. And it was about halfway through my second year, probably about October of my second year, as the application process was opening up, that I kind of then went through all those intensive care unit rotations as we did. I think we did PICU during my first year, but then it was during our second year where we spent actually our time in the intensive care unit.
Yeah, I will say my interest for critical care was definitely peaked. I was on the neuro ICU and had a patient with coagulation reversal as well, and I was freaking out, and the attending was just like, he was much more chill than I would ever expect someone to be. But Dr. Phillips, I don't believe we've yet heard from you. Back in the age of dinosaurs, when was it that you came to see the light and realize that critical care was for you? Oh, hang on. I'm sure this is a good anecdote, but I think you're on mute.
So my friend T-Rex and I were talking. I'm kidding. So I think it's important to share, and I'm glad you asked me, because I actually avoided the ICU as a medical student. I thought the patients were way too sick and they scared me. And so I intentionally didn't do an ICU rotation as a medical student. I remember even taking patients to the floor off of the ICU and looking at, this is admittedly still back in the day, paper charts, but flipping through and trying to figure out what was actually wrong with them after a 20-day stay in the ICU and taking. I thought, man, I could never do this. And it was, we did a community stint in the ICU as interns during residency. I don't liked it, but everybody did, right? We're emergency docs. Of course, we like the critically ill patient. And then second year, I did MICU, thank goodness, early in the year, because that was when I realized that I actually kind of missed the ICU when I came back off that rotation. And then it wasn't until December or January of my second year, and I was in a 3-year program, one of the few academic 3-year programs at the time. It was 3 years anyway. That I was back I was in the SICU, and I was talking to some of the couple of fellows who were there and the residents. I was like, yeah, I kind of like this ICU thing. And they're like, dude, applications are right now. And so it happened that when I had rotated through the MICU, that was the program director for the anesthesia critical care route, and things have gone well, thankfully, and so things progressed from there. But yeah, I was surprised. I would not have anticipated it, and now I love it. So if you're a student and you're watching this and you think I can't do critical care, it's too hard, you're probably going to wind up doing it, and you'll love it.
That's very fair. So this is kind of an open question for the assembled panelists. You get to go into a time machine and go back to your younger self in medical school, and you get to tell them one thing, 280 characters or less. What would you tell your younger self? And provide a little context, not just like, don't check out that library book, you'll end up liking this stuff. Something. Give us a little bit of context. Dr. Stanfield, do you have some advice for your younger self?
Oh boy, let's see here. I'm still pretty young right now, but I think, my younger self kind of got really tied up into where I was going to go for residency, or kind of exactly like what the pathway was going to look like. And I think I overemphasized a lot of that. And there's a lot to be said for kind of just taking it the one step at a time, taking advantage of the opportunities you have in front of you, and then continuing to take that next step one after the other. You don't necessarily have to have a master plan. You can have a general idea, but you don't have to have a master plan mapped up from the first day of med school and exactly how everything's going to go. And there's room for some flexibility in there. So
that's great to hear. Anybody else want to share?
Yeah, I would say if I can give myself some advice would be just we're kind of throwing a lot of things at you right now. We're talking about academics versus community. We're talking about different pathways of things, but I would just kind of seek out various mentors and keep seeking them out, and especially people who kind of changed gears or changed pathways like throughout their career, and just kind of ask them like why they ended up choosing like what they ended up choosing. Like I know I've had several mentors who switched from even just like within tracks at an academic institution. They switched like various tracks, or they switched what type of intensive care unit they worked into, or they switched from working predominantly in the emergency department to working predominantly in the intensive care unit. And so this doesn't have to be applicable to critical care even per se. This could be applicable to emergency medicine in general, is just to continually seek out various mentors, especially ones who switch processes along the way, and seek out like why they did so.
Dr. Chang or Dr. Phillips?
I think similar to what Dr. Stanfield and Hines mentioned, I think more and more, I think as we've gone along in our careers, we've noticed that there's definitely many ways to design your own career and doesn't follow any particular, steps or what we think it is. And so along those lines, it's kind of like if there's something that you think are multiple interests that don't quite go together, there's a way to put it together. It'll come to you at maybe different stages of your career, or maybe you'll be the one person who, somehow combines all of these interests of yours. So don't be afraid of that.
Yeah, I would say this is kind of cheating because echo off of Dr. Hines, but I'd always been told, find a mentor, find a mentor. In my mind, I heard the words find a mentor. And my advice to myself would be, you're not going to find a mentor. There's not one person who's going to match you, and there shouldn't be one person who matches you. So seek out different ones for different reasons. And it's okay to seek out ones who do things that you don't necessarily agree with, because you can learn from those people as well in a nice way. And then one other, if I may give two, the second one would be that it's okay to take an off-beaten track. So I did a master's in education. I paused between third and fourth year, and it scared the bejesus out of me. And I didn't graduate with my class, which at the time seemed like a really big deal because I wanted to graduate with my friends. And it was one of the best decisions I ever made. So it's okay to do a unique pathway, and you can probably speak to that too, Dan. You've had some of the medical illustrator stuff, and you share with everybody what's some of your pathway that is a little different. It's okay.
Yeah, fair enough. Yeah, I think certainly my experience as an illustrator makes me dig into the details so that when other people see my work, they're not just looking at it and going, well, that's wrong, that's wrong, that's wrong, and so on and so on. So I have to really know my stuff, or otherwise I'll screw it up and feel awful forever. But I wanted to turn it over to our audience. If you have any questions and would like to be on mic and ask somebody, burning questions, or type it into the chat box. Now is the moment. I've got a few more questions, but I want to give some time for our audience. So I'm going to prep my next question, but if you're in the audience and you have a question, let's hear it. All right. So medical students care about many things. I should know, I was recently one of them. But probably the biggest one is, what does your day-to-day look like? Honestly, at the end of the day, it's a job. And I was wondering if each of you could take a minute or two and sort of walk through, like, do you wake up and get on the Peloton and then go to work? Is the Peloton an after work thing? Is it like whenever I have the energy? Give us a sense of what the end of the tunnel looks like, so to speak.
I guess maybe I'll start because I'm still in the tunnel in a sense. I guess I'm out of the med school tunnel, but still in the residency tunnel, and finishing that and maybe to be in the kind of pre-fellowship tunnel before the fellowship tunnel. So, right now I'm working as an EM resident, doing my EM shifts. So rotating shift schedule, as we're all familiar with. And then with that, I'm also realizing I'm graduating from residency in just a couple of months here and want to do some focused studying in areas like to feel more comfortable as I get ready for independent practice. So reviewing EKGs, doing stuff like that. And I'm also doing some things getting ready for applying for the medical critical care fellowship. So, like sitting on this panel could count as one of those things, like go on my CV. I'm writing a piece for the AAEM Common Sense magazine right now. I'm getting some presentations together for our residency conference. Like that's the kind of like the day to day to me is those things. Then weather's finally good and good enough in Wisconsin for me to go hiking again too. So
I don't know about that, man. I'm still waiting for it to be above 50 on average every day.
I'll go next since I'm also closest to training, similar to like Dr. Stanford. So I am predominantly working nights right now, which has the advantage of I end up having a big shift reduction. And so I'm going to utilize that to be able to go back to actually to school kind of as an off-beaten track, as others have kind of talked to earlier, and like work on getting a master's, which I think will kind of like help set me up for my long-term career goals. What I've seen others do kind of throughout my training is it kind of just depends on like what type of route you want to go down, which you'll kind of be able to explore those the next coming years. I know like right now as a medical student, you're probably focusing more on becoming a good emergency medicine resident and then also getting into critical care fellowship. But what I've seen like for like the academic pathway, I've seen oftentimes people kind of talking similar to as alluded as like, like the attendings would ride their Peloton at 5:30 or 6:30 in the morning. And they would show up at 8 and they would have their team of people and they would start rounding and then they would work on projects in the afternoon after they were done being run. They were working on things for their various hospital committees, like and moving forth or moving their hospital forward from like a critical care standpoint. Like they would be working for things for the critical care committee. And similarly, I think the community also has that where so you might that you'll end up probably, I guess Andrew can talk about the community more as he knows that pathway a little bit more, but that's where I'm at, not too far removed from training.
Yeah, so wait, tell us what, if you don't mind sharing, what's the master's in, Dr. Hines?
Yeah, I'm going to do a master's probably in clinical epidemiology, as I like to look at outcomes, and specifically I have an interest in trauma outcomes. And then I'll be able to, I serve as a journal reviewer for a few different journals, and I think that will help me from like reviewing process, from applying for grant process, and then also just to be able to conceptualize things quicker. Because I kind of, I'm not smart enough to be able to figure out that I have a bunch of friends who can just get on Google, and if they get stuck, they can type into YouTube like how to do X, Y, Z. And so I'm just not smart enough to navigate that type of learning. I'd rather be able to have a good groundwork of knowledge or base of knowledge and to learn it in a systematic fashion.
Yeah, I can definitely appreciate that. Dr. Phillips, why don't we shift to you? What's the community ICU docs day look like?
It is what you make of it. So some of the folks in our group show up to their shifts and have a really good golf game. Some people in our group are really involved in the hospital, depending on your arrangement. So if you're in a private group versus the hospital is it has a foundation or such, you're more directly employed. What you do to keep your job, so to speak, like what your contribution and ensuring you have that job is different. So in academia, it's like the published thing, or you gotta be teaching medical students or residents, and right, you have to be doing those committees and things like that. In the community, it's all about the committees and all about the processes. So they tend to be much leaner. You don't have as much of the on the academic side. You have a lot more layers, tends to be doing a lot of the work, but they depend on you in the community to do that work, which also means that you have a lot more control of what's going on in the unit. So like just had a conversation today with the CEO. Well, that's another thing. In academia, I never met the CEO of the hospital. We're a 500-bed center, and I just had a meeting today with the CEO about the CLABSIs and CAUTIs, and working on that. That's just part of it. So you very much can show up to your shifts and leave, but you can also get very, very involved in the clinical delivery.
Wonderful. And Dr. Chang, if you wouldn't mind rounding out the conversation.
Yeah, I think ultimately the light at the end of the tunnel for you guys as students is that life does get better in terms of whether it's hours spent at the hospital or getting to do things that you've always wanted to do, or, again, designing your career the way that you envision it. And so certainly the days that when we're on service, if it's the ED shifts are, as you all know, generally hop in. The ICU has some structure to it, right? You're around in the morning and afternoons. For myself, maybe I'll have consults, and then on top of the other academic work in terms of teaching and meetings and that sort of stuff. And on our non-clinical days or weeks, then we get to focus a lot more on our non-clinical projects, which is always nice. So there's a good balance to be able to do everything you want to do.
Wonderful. I'll turn it over to the panelists here. Is there something that you guys want to get off your chest, or something that you want to make clear to medical students that maybe we didn't cover, or a soapbox you wish to stand upon for a few minutes? We have some time if there's a particular burning issue that you have.
Sure, I can jump in here. Your question about cross-pollination earlier got me thinking, and as someone who's getting ready to apply for medical critical care fellowship, looking for those fellowship programs that are going to offer really excellent cross-pollination, interdisciplinary exposure is really appealing to me. The medical ICU at the University of Wisconsin is staffed by anesthesia, medicine, EM, and seeing those different training backgrounds come together and share their perspectives is really interesting. And that's something I very much want to have in my fellowship as well, to find a fellowship program where it's not just one perspective, and you really are seeing a lot of different disciplines and training backgrounds and how to approach these problems.
Do they ever disagree significantly?
It does happen sometimes, that sometimes there are kind of different perspectives on how much something matters. Like EM people, there's sometimes a bias, oh, the high blood pressure really doesn't matter that much. It's well, we can't leave this high forever. We got to do something about it.
Fair enough. Any other closing thoughts or soapboxes, Dr. Phillips?
I would say don't do something just for your resume. You gotta, I get it. People may invite you to do something, and early on you gotta say yes and broaden things out, right? But I feel like people do research because they feel like they have to, or they do something because people getting a master's because they feel like they have to. You gotta. There is so much that you can do, and so much work you're gonna be doing. You gotta want anything that you're doing. You have to decide, right, where am I going to spend the time? So it's just not worth it. The gain that you get from whatever little thing you think you have to do, even though no one's told you, be passionate about what you decide to do. Otherwise, it'll just be too much.
Yeah, I appreciate that. I saw someone on Twitter today post a little picture of the back of a napkin where they had a sort of a loyalty card drawn out, where after 10 times of saying no to something professionally, they got a little bit of ice cream, or somebody had to buy them ice cream. I thought that was a wonderful idea, because I have trouble saying no to things as well. Dr. Chang or Dr. Hines, any sort of last thoughts or burning declarations?
I was just going to add that obviously, again, I think everyone who's in this particular career path is biased, but I think to be dual trained in EM and critical care, not only is it a clinical practice that we all enjoy, but it really affords you, again, a lot of flexibility in your kind of career and longevity, whether it is changing back and forth between how much EM or critical care you do, or is it because you get to develop, clinical guidelines and protocols at your hospital, or is it because you can, better whether it is lead clinical trials, obviously acute clinical trials, span across the patient's time in their journey in the hospital. So many ways, definitely, again, to kind of really develop your career.
Yeah, to kind of piggyback off of what the two prior said is that there's like a space for everyone based off of or based off your interests. Like I know a lot of people who really like teaching like the students and a resident who like really like that is like their high, and they end up going down the pathway of they end up getting maybe more involved in the graduate medical education, like within the hospital itself. Or there's the people who enjoy kind of like the business aspect of things, and they might to go down at the pathway of like a managerial type system. There's the people who are like phenomenal clinical experts, and everyone just kind of like looks to them, and they really own like the clinical area, and they bring so much to that field. And it's just again, it's just to find like what you enjoy doing, and there's definitely a way to make it happen. And someone has probably done some version of it, whether it's the exact version or not, but they've probably created some version of it in the past.
Wonderful. This is so useful. I don't know, I'm being a little selfish. This is so useful for me because critical care is something that I'm thinking about pursuing. And I'm at the beginning of the tunnel that Dr. Stanfill is leaving and before getting into anyway, very useful, wonderful conversations. I wanted to once again give some time and space for questions from the audience if you had one. If not, I have some announcements, and then we'll close out this webinar. But just a couple of moments for any questions from our audience, and then we'll get out of here. All right, it's a quiet house tonight, but thank you so much to our speakers for presenting. We hope to those of you listening now and then in recordings in the future, that we provided some insight into the paths you can take into critical care, what that looks like, why you might want to do it, what you might hope to look for now as a medical student heading into your career. We have some upcoming critical care section events. I'm going to list them off. Again, it's the March 24th. It's Thursday, March 24th. We have our next council membership meeting Sunday, April 24th, 10:30 in the morning. This is during AAEM's Scientific Assembly. So if you happen to be in Baltimore and hanging around Dr. Chang's hometown or backyard, please stop on by for our council membership meeting. We also have a junior speakers competition for our Breveloquent series. This will be Sunday, April 3rd at 11:30, again, also in Baltimore at the AAEM Scientific Assembly. We are looking for speakers. So if you are a medical student or resident who is interested in perhaps giving public speaking a try, sign up on our website. It's aaem.org. Under the sections, we are CCMS. You have until April 1st to sign up. Finally, we have a social event for those in intensive care. That'll be Tuesday, April 26th at 8:30 p.m. in Baltimore. It will be offsite at the Pratt Street Ale House. And I understand the first round is on Dr. Phillips, maybe not. Of course, if you haven't registered for Scientific Assembly, now is the time. You can do that on AAEM's website. Thank you all for joining us this evening, and we look forward to seeing you again soon. This is the end of tonight's program. Please have a good night and stay safe.